Professor Ali Saad, Professor of Cardiovascular Medicine. Guidelines published by international societies and organizations of cardiovascular medicine and other branches of medicine are some type of textbooks and review of literature that care for evidence-based information. That's by reviewing related trials, registries, and expert opinions to tell us what we have to be oriented to offer and avoid in diagnosing and treating our patients in our everyday practice. But they do not tell us how to do this. For example, they tell us what we have to do for patients with mitral regurg to diagnose and treat it, but not how we do the echo or mitral clip insertion for them. Every guideline I consider as a chapter of textbook. I try to make such important issues easy to understand and remember. I hope you find this of benefit to you. Thanks. This is a series of mastering guidelines in no time, and this talk will be about the ESC guidelines on heart failure 2021. Now we are going to define the heart failure. Heart failure is not a single pathological diagnosis, but a clinical syndrome consisting of cardinal symptoms like breathlessness, ankle swelling, and fatigue that may be accompanied by signs, for example, elevated jugular venous pressure, pulmonary crackles, and peripheral edema. It is due to a structural or functional abnormality of the heart that results in elevated intracardiac pressure and or inadequate cardiac output at rest and or during exercise. Identification of the etiology of the underlying cardiac dysfunction is mandatory in the diagnosis of heart failure, as the specific pathology can determine subsequent treatment. Most commonly, heart failure is due to myocardial dysfunction, either diastolic, systolic, or both. However, pathology of the valves, pericardium, and endocardium, and abnormalities of heart rhythm and conduction can also cause or contribute to heart failure. This come in agreement with the most recent universal definition of heart failure, which states that the heart failure is a clinical syndrome with current or prior symptoms and signs caused by structural and or functional cardiac abnormality as determined by an ejection fraction of less than 50%, abnormal cardiac chamber enlargement, E to E prime of more than 15, moderate to severe ventricular hypertrophy, or moderate to severe valvular obstructive or regurgent lesion. And this must be incorporated by at least one of the following: elevated natriuretic peptide levels, that is the N-terminal pro-NB equal to or more than 125 picogram per milli, or BNB equal or more than 35 picogram per milli. And the other one is objective evidence of cardiogenic pulmonary or systemic congestion by diagnostic modalities, such as imaging, for example, by chest radiogram, or elevated filling pressure by echocardiography, or hemodynamic measurement, that is, right ventricular catheterization, pulmonary artery catheter at rest or with provocation, for example, exercise. So, the diagnosis of the heart failure doesn't only require symptoms and or signs of heart failure caused by structural and or functional cardiac abnormality, but this must be corroborated by at least one of the following elevated natriuretic peptide levels, as we told before, or objective evidence of cardiogenic, pulmonary, or systemic congestion. Failure is also subclassified into three subtypes. The heart failure with reduced ejection fraction, that's HFrEF. Heart failure with mild reduced ejection fraction, HFmrEF. And heart failure with preserved ejection fraction, HFpEF. The three subtypes must have cardinal symptoms with or without signs of heart failure, and the heart failure with reduced ejection fraction have left ventricular ejection fraction equal or below 40%, and the heart failure with mild reduced ejection fraction have left ventricular ejection fraction between 41 to 49%, and heart failure with preserved ejection fraction, as shown from the name, have left ventricular ejection fraction equal or more to 50%, and the heart failure with preserved ejection fraction have in addition an objective evidence of cardiac structure and or functional abnormalities consistent with the presence of left ventricular diastolic dysfunction with or raised left ventricular pressure, including raised natriuretic peptides. Now we shall transfer to the second part of this talk, that is the diagnosis of heart failure after we defined it, and we shall refer to the class of recommendations. By class 1 it is recommended or must, and class 2A should be considered, class 2B may be considered, class 3 is not recommended. All of what we are talking about now are recommended. All we shall mention now are recommended. So class 1 recommendations, we have to do BNB or N-terminal pro-BNB with the cut of values we mentioned before in the before, and 12 lead ECG that must be done and interpreted by skilled cardiologist or personnel, transthoracic echo done by skilled personnel, chest radiology X-ray also must be done and interpreted by skilled personnel, routine blood tests for comorbidities, that's including CBC, urea, electrolyte, thyroid functions, FBS, that's fasting blood sugar, and HbA1c, lipid profile, iron studies, that is TSAT and ferritin. In case there is a bad window for the echo, which will define and diagnose the structure and the functions of the heart, we can do the cardiac CMR, that is cardiac MR, to assess myocardial structure and functions. But cardiac MR must be done for categories, even if we do echocardiography, in the case we want to characterize or for characterization of the myocardial tissues, if we suspect infiltrative disease, Fabry disease, inflammatory disease like myocarditis, left ventricular non-compaction, amyloidosis, sarcoidosis, iron overload, and hemochromatosis. Also, it is recommended to do invasive coronary angiography for patients with angina despite the pharmacological therapy or symptomatic ventricular arrhythmia. Also, we have to do cardiopulmonary exercise testing for evaluation for heart failure patients for heart transplantation and or mechanical support devices. We must also do right heart catheterization for severe heart failure evaluation for heart failure transplantations or MCS. Now we will transfer to the treatment of heart failure. To reduce the risk of heart failure hospitalization and death, it is recommended to give ACE inhibitor, beta blocker for stable heart failure with reduced ejection fraction, mineralocorticoid receptor antagonist, dapagliflozin or empagliflozin. Sacubitril valsartan is recommended as replacement for an ACE inhibitor. NRB in symptomatic patients unable to tolerate an ACE inhibitor or ARNI. Diuretics are indicated in patients with heart failure with reduced ejection fraction with signs and or symptoms of congestion to alleviate heart failure symptoms, improve exercise capacity, and reduce heart failure hospitalization. Also, it is recommended to give to insert ICD to reduce the risk of sudden death and all cause mortality in patients and who are expected to survive for more than 1 year with good functional status. If the patients will live for more than 1 year as expected with good functional status and indicated to insert the ICD, we will do it. It is recommended class 1. Patients who have recovered from ventricular arrhythmias causing hemodynamic instability in the absence of irreversible causes or unless the ventricular arrhythmia has occurred less than 48 hours after myocardial infarction. In patients with ischemic symptomatic heart failure, NIHA class 2 to 3 and an ejection fraction, left ventricular ejection fraction equal to or less than 35% despite more than 3 months of optimal medical therapy unless they have had an MI in the prior 40 days. RT is recommended for symptomatic patients with heart failure who are in sinus rhythm with a QRS duration equal to or more than 150 milliseconds and left bundle branch block QRS morphology and with left ventricular ejection fraction less than or equal to 35% despite optimal medical therapy in order to improve symptoms and reduce morbidity and mortality. Also, CRT rather than RV pacing is recommended for patients with heart failure with reduced ejection fraction regardless of NIHA class or QRS width who have an indication for ventricular pacing for high degree AV block in order to reduce morbidity. This includes patients with AF. Recommendation for treatment of patients with heart failure with mild reduced ejection fraction and heart failure with preserved ejection fraction, heart failure MREF or heart failure BIF. Diuretics are recommended in congested patients with heart failure with mild reduced ejection fraction and heart failure with preserved ejection fraction in order to alleviate symptoms and signs. Screening for and the treatment of etiology and cardiovascular and non-cardiovascular morbidities is recommended in patients with heart failure with preserved ejection fraction. Recommendation for the prevention of chronic heart failure. The following are indicated to prevent or delay the onset of heart failure and to prevent heart failure hospitalization. It is recommended to treat hypertension, also to treat with statin in patients with or at high risk of cardiovascular disease. Also to use the sodium glucose transporter 2 inhibitors like canagliflozin, dapagliflozin, empagliflozin, ertogliflozin, sotagliflozin in patients with diabetes with or at high risk of cardiovascular disease. Also, it is recommended that we have to offer counseling against sedentary habit, obesity, cigarette smoking, and alcohol abuse. Other recommendations for management of chronic heart failure. The following are recommended to reduce the risk of heart failure hospitalization and mortality. Heart failure patients are enrolled in multidisciplinary heart failure management program. Also, it is recommended self-management strategies, either home-based and or clinic-based programs, and also improve the outcome. This also, in addition to the reducing the risk of heart failure, hospitalization, and mortality, also it will reduce the or improve the outcomes. Exercise is recommended for all patients who are able in order to improve exercise capacity and quality of life. Also, it is recommended for the treatment of the patient with advanced heart failure patients being considered for long-term mechanical support must have good compliance, appropriate capacity for the device and handling, and psychological support. Heart transplantation is recommended for patients with advanced heart failure, refractory to medical or device therapy, and who do not have absolute contraindications. Recommendations for treatment of acute heart failure. All the following are class 1 recommendations. Oxygen is recommended in patients with transcutaneous oxygen saturation less than 90% or partial oxygen pressure less than 60 mm mercury to correct hypoxemia. Intubation is recommended for progressive respiratory failure persisting in spite of oxygen administration or non-invasive ventilation. Intravenous lobe diuretics are indicated for all patients with acute heart failure admitted with signs and or symptoms of fluid overload to improve symptoms. Also, the thromboembolism prophylaxis, example Gracia, with low molecular weight heparin in patient not already anticoagulated and with no contraindication to anticoagulation to reduce the risk of DVT and pulmonary embolism. Recommendations for management of patients after heart failure hospitalization. It is recommended that patients hospitalized for heart failure to be carefully followed or evaluated to exclude persistent signs or congestion. Persistent signs of congestion before discharge and to optimize oral treatment. So we have to carefully evaluate the patients for signs of congestion before the discharge. It is recommended that evidence-based oral medical treatment to be administered before discharge. An early follow-up visit is also recommended at 1 to 2 weeks after discharge to assess signs of congestion, drug intolerance, and start and or up-titrate evidence-based therapy. Recommendations for treatment of patients with heart failure and AF. Long-term treatment with an oral anticoagulation is recommended in all patients with AF, heart failure, and Cardiovascular score more than 2 in men or 3 in women. Direct oral anticoagulants are recommended in preference to vitamin K antagonists in patients with heart failure, except in those with moderate or severe mitral stenosis or mechanical prosthetic heart valves. But we have to mention here that although Realign trial that compared dabigatran to warfarin in patients with mechanical valve prosthesis and was terminated prematurely because of an excess of thromboembolic and bleeding events among patients in the dabigatran group. But rivaroxaban in mechanical valves study, RMV study, that compared rivaroxaban 20 milligrams daily with dose adjusted warfarin targeted INR of 2 to 3 in patients with atrial fibrillation and bioprosthetic mitral valve, and found that the rivaroxaban is non-inferior to warfarin as regards the efficacy and risk of bleeding. Also recommended class 1 recommendation urgent electrocardioversion in the setting of acute worsening of heart failure in patients presented with rapid ventricular rates and hemodynamic instability. Treatment of heart failure in different comorbidities. We start with aortic stenosis. It is recommended that aortic valve intervention, whatever it is TAVI or SAVR, that's surgical or transcutaneous intervention, is recommended in patients with heart failure and severe high gradient aortic stenosis to reduce mortality and improve symptoms. It is also recommended that the choice between TAVI and SAV be made by the heart team according to individual patient's preference and features including age, surgical risk, clinical, anatomical, and procedural aspects, weighing the risks and benefits of each approach. Recommendations for treatment of patients with heart failure and diabetes. SGLT2 inhibitors, that's CANA, DABA, IMBA, ERTO, SOTA, gliflozins, are recommended in patients with type 2 diabetes mellitus at risk of cardiovascular events to reduce hospitalization for heart failure, major cardiovascular events, end-stage renal dysfunction, and cardiovascular death. SGLT2 inhibitors, DABA, IMBA, and sotagliflozins are recommended in patients with type 2 diabetes mellitus and heart failure with reduced ejection fraction to reduce hospitalizations for heart failure and cardiovascular deaths. Recommendations for treatment of patients with heart failure and iron deficiency. It is also recommended that all patients with heart failure to be periodically screened for anemia and iron deficiency with a full blood count, serum ferritin concentration, and TSAT. Recommendations for treatment of patients with heart failure and central sleep apnea. Adaptive servo-ventilation is not recommended in patients with heart failure with reduced ejection fraction and a predominant central sleep apnea because of an increased all-cause and cardiovascular mortality. Class 3A. Recommendations for treatment of patients with heart failure and cancer. It is recommended that cancer patients at increased risk for cardiotoxicity defined by history of risk factors of cardiovascular disease, previous cardiotoxicity, or exposure to cardiotoxic agents. Those patients must, or it is recommended to undergo cardiovascular evaluation before scheduled anti-cancer therapy, preferably by cardiologists with experience or interest in cardio-oncology. Recommendations for treatment of patients with amyloidosis. Tafamidis is recommended in patients with genetic testing, proven hereditary or wild-type transthyretin cardiac amyloidosis with NIHA class 1 or 2 symptoms to reduce symptoms, cardiovascular hospitalization, and mortality. We are talking about medications or interventions that are not recommended. That's class 3 indication. The addition of an RB or renin inhibitor to the combination of an S inhibitor and an MRA is not recommended in patients with heart failure because of the increased risk of renal dysfunction and hyperkalemia, class 3C. ICD implantation is not recommended within 40 days of an myocardial infarction, as implantation at this time does not improve prognosis. That's class 3A. ICD therapy also is not recommended in patients with NIHA class 4 with severe symptoms refractory to pharmacological therapy unless they are candidates for CRT, a ventricular assist device, or cardiac transplantation, class 3C. Also, inotropic agents are not recommended routinely due to safety concerns unless the patient has symptomatic hypotension and evidence of hypoperfusion, class 3C. Routine use of opiates is not recommended unless in selected patients with severe or intractable pain or anxiety, class 3C. Intra-aortic balloon counterpulsation is not routinely recommended in post-MI cardiogenic shock, class 3B. CRT is not also recommended in patients with QRS duration less than 130 millisecond who do not have an indication for pacing due to high degree AV block, class 3A. Also not recommended, that's class 3 recommendation, the treatment with antiarrhythmic agents, flecainide, incanide, diazopyramide, also dronedarone and disotalol is not recommended due to safety concerns. Diltiazem or verapamil are not recommended in patients with heart failure with reduced ejection fraction, as they increase the risk of heart failure worsening and heart failure hospitalization. Thiazolidine, diones, glitazones are not recommended in patients with heart failure, as they increase the risk of heart failure worsening and heart failure hospitalization. The DPP-4 inhibitor, saxagliptin, is not recommended in patients with heart failure. Adaptive servo ventilation is not recommended in patients with heart failure with reduced ejection fraction and a predominant central sleep apnea because of an increased all-cause and cardiovascular mortality. Recommendation for treatment of patients with heart failure and arthritis, non-steroidal anti-inflammatory drugs or COX-2 inhibitors are not recommended in patients with heart failure, as they increase the risk of heart failure worsening and heart failure hospitalization. Treatment of anemia in heart failure with erythropoietin stimulating agent is not recommended in the absence of other indication for this therapy. Abbreviations. Thank you. Please follow us for more talks from this series of Mastering Cardiology and one master slide cardiology. Thank you very much.